Hello, everyone. How are you? We were certain that someone from BHT was going to give us a little bit of detail here, but we decided we didn't want to keep all of you waiting. So we have a really exciting panel today with some great folks that I'll allow to introduce themselves in a moment, talking about value-based care, theory or practice. So it's a buzzword, but what does it actually mean? What are people actually doing about it? And we're excited to talk a little bit about that today. So it'll be a 45-minute panel. We'll try to do some Q&A, and I believe that you all can submit questions on, I think there'll be some detail there, QR code to submit the questions, and we'll try to take those at the end of the panel. So if you don't know, my name is Robert Crane. I'm the co-founder and CEO of Talkiatry, which is a full-stack digital provider group focused on behavioral health, of course, but we have a very specific subspecialty on psychiatry, so we're one of the largest employers of psychiatrists in the country and have a big focus on quality and helping move the industry to a value-based care framework. So with that said, obviously, there's been a big explosion of access in behavioral health over the last several years, which is great, I'm sure, for everybody in the room. But we've seen payers and our partners now looking at evaluating their network and saying, what am I providing access to specifically, and how am I providing that access? And that's been very interesting to us as the industry has kind of caused a shift to more of a quality-oriented mindset, which we're incredibly excited about. And as the space matures, it's becoming evident that there are very large differences in how provider groups are measured in a lot of different subspecialties in behavioral health. They all can't be measured the same, and so how are we figuring that out, and how are we translating that into how we're getting paid at the end of the day, right? And aligning incentives across patients, payers, and providers. So I think what I'll do is allow the panelists to introduce themselves, and then we'll get into some exciting conversation.
So good morning, everyone. I'm Andrew DiGiacomo. I am the director of our National Provider Network Strategy at Evernorth Health Services, which includes our contract innovation teams, our provider experience teams, and also our market management. Really happy to be here and connect with all of you on this subject.
Hey everybody, Andy Kelly. I lead provider enablement at Optum, which is all things value-based programming and then provider partnerships. Great to be here. Been with the organization 10 years, in behavioral for 5, and a dad of 3 and 2 dogs.
All right, hello, Taft Parsons. I'm the Chief Psychiatric Officer for CVS Aetna, with responsibility over kind of the Aetna side with our psychiatrists that are doing bread and butter health plan medical director stuff, but also with some responsibility over quality of care that we are providing on the CVS enterprise side, like through Minute Clinic, collaboration with Oak Street Health, Signify. So nice to be here.
Hi all, great to be here. I'm Rachel Goldberg. I lead strategic partnerships and product innovation for Horizon Blue Cross Blue Shield of New Jersey and for our spin-off organization, NovoWell, which is a spin-off of Horizon Behavioral Health. NovoWell is aimed at helping health plan partners to expedite their own behavioral health strategies. So it's been very fun to help health plans figure out and combat the same challenges that we did at Horizon. So great to be here. Thank you.
Awesome. Very, very relevant panel here, of course, for this discussion. So I'm excited for all of you to hear. Before we get too far into the future on value-based care, I mean, I'm sure there's a lot of people in this room who either have gotten the chance to speak to you or want to get on your calendars, I'm sure. I'm sure when you're thinking about this, there's really endless options. There's people focused on engagement, people focused on very specific outcomes, all of which are incredibly important. I think just to open up to the group, how do you figure out how to spend your time in these types of areas with so many people trying to come up with solutions? And like, how do you think through that for the people in the audience who kind of want to get on the calendar?
I'll start. We started evaluating different types of digital and virtual solutions in 2017 and as a way to be innovative and increase access. And at the time, there were like 5 different companies that you could talk to. And I used to troll LinkedIn looking to see if someone would talk to me. And they're like, why would I talk to a payer? Now things have changed. There are so many different companies at this point. And at the very top of our list is are you based in some sort of evidence-based practice that is actually going to get people better or help providers to get people better? And that's basically our initial screening criteria for the most part.
I think the other thing we think about is what are our problems? I think as all of you probably have different problems, a lot of them are the same. And I think a lot of what we spend our time in is sort of falling in love with those problems. I think Rachel has mentioned there's endless solutions, but how do you really go deep on the problem and ensure that where we're spending our time is actually going to make a difference in the lives of those that need that care? And with anything, right, time is limited, time is valuable, and figuring out what that prioritization is and then ensuring that that aligns across the organization is something that we work on every day.
Yeah, I will say, I think probably eventually everybody gets on my schedule or a couple of my counterparts' schedule. So, don't fret if you haven't been on it yet. You'll probably get there. So I think a couple of things. One is that, when we're meeting with different provider groups, vendors, one thing is to kind of just take, really just listen and take in some of the information about what they are seeing, who they're talking to, what are the things that they find as important, and how do they demonstrate that they're providing really good care. The other part is kind of internally. So we as a company also working on what are the things that we value for our membership, and how we treat different structured and different sized companies may be very different. So the type of contract that we have with an Alma is going to be very different than the type of contract that we have with either a Talkiatry or an Equip or something that's a little bit smaller. So figuring out what are the things that that company can do and does do, and what do they do well, and what do we value that they do, changes kind of what we may look to structure in a contract or spend our time kind of focusing on how do they demonstrate that better.
Yeah, and just to jump on that, Taft, when we think about getting onto our calendars and how busy we all are, we like to look immediately at outcomes. So when we jump onto a call with any of the provider groups, we want to make sure we're aligning on somewhat of an agreement on what we're looking for outcomes, because if we jump into these meetings and we're not agreeing on that from the start, then we know that, to your point about contracting and how we approach, we're not going to get very far down the road. And to that, the last part is we also love to see provider and partner flexibility. Are you willing to jump in with us and be creative and then, get to that final point together?
Makes sense. And then, Taft, just to follow up, I'm sure there's clinicians in the room here. You're the only doctor on the stage. I'm curious how that influences or provides any slight difference in terms of how you evaluate these things, whether before you speak to the team or during conversations with teams.
Yeah, I will say that it probably gets contrasted more obviously in internal conversations, depending on kind of what group internally somebody is coming from. There's going to be different things that they value. So, our network partners have certain things that they're looking for in a provider partner. Our product team has certain things that they're looking for in a provider partner. And us as clinicians, we have certain things that we look for to ensure that, as our membership goes to these providers for care, that it is demonstrably clinically good care. And so the things that we're all paying attention to are slightly different, but all kind of intertwined and related.
Yeah.
And so the question then becomes how much of it and what things and how much of it do you try to put into a contract? Because you can't just kind of exhaust people with hundreds and hundreds of things that they have to do and hoops that they got to jump through in order to get, a 5% extra or whatever the boost is that we're negotiating. But, so what are the, 3 or 4 things that we think are really important? How much of that is clinical? How much of that is financial utilization? And so how do we figure out what are the most important things for an organization? And sometimes, yes, being a clinician, my bend is always towards the clinical care, but that's not kind of the only factor that we pay attention to as we speak to potential partners.
Definitely. And then, to kind of move further down the chain here, You know, I always think about value-based care as almost like grades in school, if you will. So there's kindergarten value-based care, which is not really value-based care, but it's a step in the right direction. And then there's college grade value-based care, which you could argue is global capitated risk, which is obviously very difficult to do in behavioral health because we don't have necessarily, at least in general, that kind of primary care touch point. And so I'm curious for the group here, where you think we are on our journey, or where are each of you kind of in your individual journeys, and just how do you look at that? Where would you like to be in the next, I don't know, 2, 3, 5, 10 years? And I think it's important to kind of anchor folks because everyone talks about it a lot, but where are we? What are we actually doing here? Would be great for people to hear.
Yeah, I'll lead off. So as we look at our journey, I would say we're still trying to start small and be really specific to the things that our clients are looking for. And going back, Taff, to what you said a little bit about the administrative burden, I think there has been somewhat of an history in value-based care of a ton of metrics getting thrown out, and it became such a burden on providers that it burned them a little, right? And so where we're at is talking with our clients, our employers, what's so important, access is vital, and then really getting specific at which acuity groups that will be important for, and then eventually in the next 2 to 3 years, continuing to grow that out of that scaled approach.
Got it. Yep. I guess Andy, specific question, right? I mean, Optum is a bit unique. It employs a really massive number of providers, across the country in different specialties, of course, not just in behavioral health, which is really interesting. So you guys have a lot of experience on value-based care outside of behavioral health, and I'm curious where and how that plays a role in how you evaluate behavioral health, value-based care, just given it is so different. You don't necessarily have all the metrics or all of the ownership of the patient per se.
Yeah, that's a great one. So I'll start with everybody loves a good firewall. And so to that point, we don't have a lot of visibility into what our employed clinicians do and how they contract with other payers. But to that end, what we've tried to do is really look at sort of 2 different angles. One is from a provider lens, and really, where are they? And so part of this idea that my team, it's not called the value-based care team, it's called provider enablement for a reason. And really what we said is value-based contracting is part of what we do, but more importantly, we are in the business of trying to enable providers with data, insights, analytics, clinical insights that we have that they don't. And so that was one of the key things that we looked at what we found and said, hey, we're not seeing a lot of that, whether it's from our Optum colleagues or others, and so let's lean in there. And then sort of in the reciprocal is, what do we need? And how do we think about our acuity groups? How do we think about, what RFPs look like? And really, what does Medicaid and Medicare, and how does that differ from commercial? And so I think there's a lot of differences in terms of, back to your sort of, grade school analogy, like is where we are. And I think we've been able to move at the pace that providers have wanted to an extent. But I think sort of once you hit middle school, it's far harder to get an organization to get past some of that organizational inertia around here's how we've done it, but let's move forward, right? And so there's been a lot of challenging the status quo in terms of some of the things you mentioned, like attribution or this global risk idea, but still a long way to go.
Yeah, makes a lot of sense. Go ahead, sure.
Yeah, I'll just chime in on that. So, with us, we own Oak Street, which takes on total global risk. We contract with lots of providers on the Aetna side that are large PCP practices taking on risk, and then we're also working within behavioral health to try to figure out, what do these value-based contracts look like when you're just talking about a specialty provider, and the manner in which we work with those different groups is significantly different. So on the primary care side, they just take all the risk. You might carve out, a couple of things like inpatient catastrophic cases. Okay, fine. But in reality, they're going to be responsible for not just the physical health outcomes, but also the behavioral health outcomes. So like Oak Street has a formal collaborative care model of care. Yep. And so they have their own behavioral health teams. It's a multidisciplinary team. They take care of social determinants of health. And so it is a very comprehensive manner in which that PCP clinic manages the patients that are going there. Whereas one of the things that we find that becomes a complexity is within our provider network where, we do not have a risk-taking PCP, and then we have perhaps a behavioral health provider who wants to take on some risk. It becomes difficult to figure out, how do we do the attribution?
Yeah.
How do we administer that contract?
Sure.
How do we as the payer look at improvements in things like diabetes outcomes, okay,
Yep.
for somebody who, we're doing some sort of value-based contract with a behavioral health provider.
Yeah.
One of the things that I have said probably more than enough times is that I have yet to meet a primary care provider that doesn't want to take credit for improvements in diabetes care.
Yeah.
And it doesn't matter that
Sure.
the only thing that was different was that they got that patient into a behavioral health specialist.
Yep.
Just one more comment on the value-based umbrella overall. There are like 1,000 different definitions of what value-based care actually
Sure.
is, which can actually create a lot of challenge when you're sort of either negotiating with someone or partnering with someone, because if you're not talking about the same definition of what it is that you're trying to accomplish, it's never going to match. So for us, it's pay for performance, evaluating sort of standard metrics, which back to your kindergarten point is like
Yeah.
very kindergarten,
Sure.
but unfortunately, there is no standard of measurement across the country, which is the other thing that we all face all the time. And then more interestingly are things like episodes of care or case rates, and trying to sort of support and empower the providers to do anything in their power to get somebody better, which changes the payment model.
Yeah, and again, I mean, I think when Talkiatry kind of looks at these things, we try to say, can we build a matched cohort? And the view is kind of looking at it saying, hey, if we're not treating this patient, should they be expected to cost more if someone else were treating them? And try to look at it on a patient-matched cohort basis versus a provider-matched cohort basis, which is probably the more traditional way to do these things. But there's such a high variability in the types of patients being treated in behavioral health, and saying, can we get the cohorts big enough where some of these things start to even out? And we just say, what's the total cost of care between these? Inevitably, you will have large chunks of that carved out, saying, hey, we're not paying on this, they're in another program, they're assigned to somewhere else, and just try to start measuring things to try and look at in the future, how do we take care of that attribution down the road, which is always going to be an important question, if you will. Rachel, but to go back to something that you said, which I think is really interesting for Andrew, is you talked about there's no standard to measure some of these things, because every diagnosis arguably has a different, more clinically validated way of measuring it. But something Evernorth has been focused on is trying to kind of do some standard of measurement-based care and try to get to a point where they can evaluate different providers in the space. Can you talk a little bit about that and what you guys are doing there?
Yeah, so earlier when I said when we talk about outcomes, right?
Yeah.
To us, there's three things we want to accomplish first with most of our provider groups when we start to jump into this. The first is concentration on simple measures, right? First getting to time to care, therapeutic alliance, and then using some of the data that we have in terms of our whole person health model for total cost of care savings, right? Because to your point, we want to make sure we're concentrating on whole person health. That's one. Two is really getting that two-way data alignment so that we're reducing administrative burden for the providers. And when you do that, then you can get to scalability. And then the final part, and we've been concentrating on this for some time in the past 2 to 3 years, is how do we develop stronger provider partnerships so that instead of us going and dictating to the provider groups what we're going to do, we're using a creative approach where we're sharing the data, and then in those partnership meetings working with these provider groups to say, hey, maybe we should be thinking about these things. In just the first year in some of the pilot programs we've done, in terms of therapeutic alliance and time to care, our alignment on those with some of our provider groups who jumped in with us was 95, 98% onto the metrics, which when you think about what's important to us on the commercial side, it's still access, but it helps us lead to what's the next step, which is once we go past access, it's how do we get to those total cost of care savings, which are so important.
Yeah, and maybe to open it up to the group here, I mean, what kind of data are we talking about that's bi-directional that people are sharing, and maybe what are you not getting that you would like to get?
I'll start. So one thing that kind of at baseline all the payers get is we get a humongous amount of data about a very limited set of things. So this is the stuff that comes across in a claim. So it'll be like, what's the diagnosis, who provided the care, what type of setting was it in, and what was the actual service. And so, we get a lot of that type of data, but, underneath it, it's just units of service. It doesn't say anything about the quality or the type of care that somebody got actually in that office, be it virtual or brick and mortar. What we have done over time is that we use that large set of limited data to extrapolate all sorts of different things. So we talk about, like member engagement. So that's like claims that say that they show up on a regular basis rather than go a couple of times and then just drop out. But it doesn't necessarily measure exactly how that member is actually engaging with the provider in the office. Yep. They might just show up and cross their arms and sit there for 45 minutes. We don't know. As we kind of talk to and work with companies that have a bit more technological capability in their EMR, we do things like we can set up APIs to move some data back and forth. And then we start to get things like patient-reported outcome measures, the PHQ-9s, the GAD-7s, some things for like specialty conditions. And so we can take that data in and we can kind of use that along with some other providers that may be providing us the same type of information to make some judgment over like, are these members that go to this provider getting better?
Yep.
That still is a very limited set of providers and a limited amount of information, doesn't really get at whether or not the actual care delivered was evidence-based treatment.
Yeah.
It just says that this person shows up and these scores go down, and so therefore they are getting better as they show up for care. We also don't get that sort of data from the majority of our network, because a lot of our network is still very small providers who have very limited capability, very limited capital funds in order to invest in things like meaningful use EMRs. Yep. And so, we are generally working for most of our network with that very limited set of data that we still get from claims.
Got it. Super helpful.
I think the thing we found is that as we went to providers, it wasn't necessarily about how much information we could give them. It was about, could we give it to them in an actionable way and have that actually drive something they could do. And so what we've tried to do is really figure out, what can we tell a provider, like, hey, this individual did not pick up their meds. We know that. And so that drives an action. They can make a phone call, pick it up, and call it. They may not even be the prescriber, right? But they have that treating relationship, therefore we can send that information. The other piece that we've started to do is really look at total cost of care. So how do we identify the members in a provider's care who have high cost, who have high spend, regardless of if it's behavioral or medical? And then in addition, pairing some additional physical health information so that it's not about, hey, you're gonna go treat their diabetes in a session, but hey, you know that they also didn't pick up their insulin that they needed. And so it's all those little different pieces of around, not here's a giant claims dump, figure it out. Although there are some providers that want that and need it and get to run all kinds of fun algorithms and stuff like that. But what we found is a majority of providers want to know just enough to be smarter, to take better care of an individual in session or when they see them. And it doesn't have to be this rocket science-y thing where everyone gets to see everything, but rather focus on actionable information. And then reciprocally, as Taff mentioned, claims was good for a while, but it doesn't tell us if people are getting better. And especially if you think about the commercial population, somebody goes and has 52 therapy sessions a week. We'll cover it. Do they need it? Are they getting better? Should they step up to IOP? All the things that we don't know. I would argue it's probably easier in the government space to use claims to make some of those generalizations, but in the commercial space where an ER visit or an inpatient event may not be sort of worst case, you need some additional information to figure out, are people going to work? Are people happy at home? Are they able to get out of bed? All of these things that traditionally never show up on a claim, probably shouldn't, but is part of how we work together as partners in the industry to make sure people are getting the care that they need.
Yeah, and I'm sure there's going to be a line around the corner for you afterwards trying to figure out how to get access to those APIs that you mentioned there with all that juicy detail. I'm sure there's a bunch of people saying, trying to figure it out. So he'll be posted up right here afterward to give you those details, I'm sure. You mentioned total cost of care. I do want to double click on that for a moment. Because when we have done some of these match cohort analyses, depending on the state, of course, we've shown that we can reduce the total cost of care by up to $700 per member per month, which is a really astronomical number. And I think obviously that goes down when you look at it nationally, but we've still shown savings of a few $100s per member per month. When you contrast that with what the cost of providing behavioral health services is compared to the savings, it's a tricky thing to balance, right? Just given the walls placed up in certain organizations, and so I'm just maybe I'd love to hear from some of you on how you look at those things, but also what are the things that, how is it internally, right? Because it's always one side is paying out the cost of that increased care, and the other one is benefiting from it, right? So that's always I'm sure a struggle, but I'm just curious how you all are trying to tackle that.
Happy to start. So I joined the Horizon team when Horizon Behavioral Health did not yet exist, and our overall goal was needing to really change the culture around how Horizon as an organization thought about behavioral health and the fact that your brain is connected to the rest of your body and behavioral health needs to be invested in. And that's how we began, which was how can we increase the access in the network? How can we appropriately pay providers? How can we do different types of payment arrangements to take care of people in ways that they hadn't previously? How can we insource our behavioral health program to make sure that people are taken care of in a holistic approach? We weren't intending to create a new company, but what we realized was by sort of changing the culture within the organization and ensuring that everyone really understands the value of integration, we totally changed the way care was delivered and in turn got people healthier, which, if you end up doing the right thing, money will follow in the end. And that became essentially the North Star of why we created NovoWell and had to, again, change the sort of cultural phenomenon within our health plan clients of what dollars they're trying to save and not. And in my personal opinion, behavioral health is not the place to try to curb cost necessarily. It's really important to get people the appropriate care that they need and to ensure that care does the right thing, which is to get the person better.
Yeah, I'm going to second that. So, over time, and I'm not exactly sure when it started, behavioral health got itself into a place where because there were, at a certain point, a lot of questions about the benefits of behavioral health and getting people treatment. And then we found that, these members or patients, whichever side they're sitting on, when they have a behavioral health disorder, it costs much more to manage them than when they don't. They have worse health outcomes. And so we kind of got into this cycle of behavioral health providers feeling like they had to make a case for how they're going to decrease total cost of care in order to justify contracting, some innovative care model, some value-based contract. And actually, that's not the bar that we make orthopedic surgeons jump over.
Yep.
And so when you look at other specialties, nobody says, hey, the renal docs, they can't, unless they can demonstrate that they're actually reducing total cost of care, we're not going to, let our members get dialysis from them.
Sure.
Like that doesn't happen. And so somehow this has happened in behavioral health in a place where a lot of the actual outcomes are a lot squishier than on the physical health side of medicine.
Yeah.
And so one of the things that we tend to find is that, we will have providers come and say, hey, we're going to save you this much money per member per month on everybody that's matched and comes to us. And then we look at it across our network and we look at care as usual, so the broad provider network compared to this provider, and more often than not, we don't find that it's better than the rest of the network. And so it makes it very difficult, if that's the value prop, to justify these enhanced contracts, to justify a value-based contract. But I think we're starting with the wrong premise. We get people the behavioral health treatment that they need because it's clinically the right thing to do. And yes, there is a value to that, But if we make the bar, you small behavioral health provider have to demonstrate reductions in total cost of care with these people that have a slew of physical health chronic conditions. I think that's an inappropriate bar to make our behavioral health partners jump over. And I bristle a little bit when that's the value prop that's being brought to me.
Yeah, I mean, listen, I think there's a lot of people in the room who would agree and are thankful to hear that as well, right? So, yeah, a little round of applause there.
I still work for a payer, so,
Yeah, so that's it's super interesting. I mean, to go back, Rachel, for a second, I think when I was looking at your website, literally, the impact of behavioral health, reducing the total, literally what you guys were built around to a certain extent. Yeah. I'd love to just try and understand how you work with your partners to do that. If you're providing the behavioral health and there's a separate insurer, and so do you have insight into that total cost of care, or how are you managing that again with the contract piece, which is you have a deliverable, but also that's not always appropriate necessarily to manage all the provider network against. And so how do you think about that?
Yeah, it's a great question, and you're exactly right. Integration really was the reason why we were created, to try to help insurance companies just think about things differently. It's a lot easier when we're playing in the Horizon space because we're born out of Horizon and we can see everything and prove outcomes and prove that we're seeing reductions in higher cost of care and that people are filling their physical health medications, et cetera. On the plan side, when we're working for a plan and bringing them our network of providers, we have to work together and essentially teach them or partner with them to do the same types of analyses that we've done in the Horizon space. But it is way more than just looking at things at the end of a 12-month period of time. It's really teaching their organization about the value of integration also, and stigma reduction, and talking with their physical health case managers about the importance of assessing people holistically, because we could bring an excellent network of providers that we've contracted with and have great outcomes, but at the end of the day, if the organization from a cultural perspective isn't into it and doesn't understand the general value of why, then it won't work. The other thing that's actually very interesting, and you made me think of it, when we talk to payers, they say like, oh, well, we already have some psychiatrists. We don't need any more. It's fine. And so, well, would you ever stop? Number one, would you ever say like, oh, I already have one primary care practice, so we're good?
Yeah.
And that's, again, another sort of like cultural phenomenon that we're working with to say, more is valuable. If you can get people in faster, make sure that they're better, there's never going to be enough. So it's the job of the payer and us on behalf of the payer and all of the providers to work together to really ensure that the supply that we have fulfills the need.
Awesome. And so I have a kind of a more thought-provoking question, right? So I think we have some really great insights here in terms of the cost of behavioral health and how different payers look at it, or individuals in those teams look at it. I think there's still a fair argument to be made that just the line item of providing behavioral health costs has increased significantly, over the last several years, right? With large groups being built, whether that's in therapy or psychiatry, if you will, and how much of that was captured outside of the network with people paying cash previously, which is now shifted, right? So eyes on it, regardless, good, bad, otherwise, right? It's an important piece that's driving costs for sure. I think the stat that I've seen is the cost of caring for a patient who's got a chronic physical condition and comorbid behavioral health condition can range anywhere from 3 to 7 times more than if they just had the physical condition alone. Coupled with, historically, there's been a pretty large, I would say, pay differential between behavioral health providers and other providers in other specialties, whether it's an MD versus an MD or other types of things. And I think we've come a long way for that, just to be clear, credit to all of you on the panel for that. But there's probably some more ways to grow there. And so how do you think about someone who is providing a differentiated experience or a differentiated cost, for example, or reducing total cost of care, or just something like how would the people in this room, if they believe that that's what they're doing, what's the path for them to approach you to get compensated for that, right? Understanding that going and just asking for higher fee-for-service rates doesn't necessarily align what everyone's interested in, right? So what is the path that you look at saying, hey, here's how we can structure these things or look at those things?
Herein lies the challenge.
Which is why it's a thought-provoking question, right? I saved it to the end.
It's a really good question. So I'll start with just at a very high level, and I never get into like specific contract negotiations, so take everything I say here with a grain of salt. The payers don't create reimbursements for behavioral health providers out of thin air. You know, these things work off of fee schedules that are endorsed by CMS, that are created in large part by the AMA. And so on some level, the fee schedule that is endorsed by the government, that is created by the AMA, is how much the AMA and all of our medical specialties value non-procedure-based care. Procedure-based physicians get a lot higher compensation per thing that they do than non-procedure-based clinicians. And there is wiggle room within that, you know, so when we can make that value prop case, when we can find an ROI, you know, we can pay an enhanced contract to somebody who's doing good work that demonstrably benefits the membership. But it's not out of thin air. And so I just want to set that as a base. Now, over the last few years, we have seen a lot of very enhanced and creative models of care created through the pandemic that I think clinically generally make sense and I think are engaging to the patients that are coming to these providers. Where we end up with challenges is demonstrating that enhanced model of care actually leads to better outcomes that have an ROI that justifies the financial premium that it costs to run that program. And that's where it's been, you know, much more of a challenge for multiple reasons. One of which, even a big behavioral health provider is still kind of small. The dollars that go to a big behavioral health provider is always going to be smaller than what goes to like a mid-sized surgical practice.
Yep.
And so it becomes very difficult to get enough power, you know, when you study it,
Yep.
to say that objectively this is more cost effective than that. And so, you know, I will say, and don't want to speak for other folks, we will try things, you know, and we will watch it and we will study it at the end. And the kind of unfortunate part is that more often than not, we've found that it's kind of a wash. It doesn't, you know, at the end,
Sure.
You can't demonstrate that it is better, that those outcomes are better, that financially it's better to have this enhanced model of care.
Yep.
And that's a challenge in the space that we have to deal with internally when we want to create value-based contracts or pay an enhanced rate.
Sure.
I think the other thing to think about is even just being able to ask that question is something we couldn't have done 5 years ago.
Yeah.
And so I was hired into Optum from a part of United Health Group, and they asked me to look at total cost of care to figure out what it was. And that then morphed into this value-based care thing and all sorts of other things. And we wouldn't have asked that 5 years ago. It would have been like, hey, Optum, you do this, United, you do that, never the two shall meet. And so I think there's some value in saying, we're not there yet, 100%.
Agreed.
But we're also light years ahead of where we were, right? And being able to run the analytics together and do some of those things. So I think super pragmatically, right, I think there's a realization that coming to a payer and saying, I want more money is not the way to start that conversation, right? I think that immediately sets you up to say, let's just race to the bottom, nobody wins. It's not about that. As much as I think that is a lot of sort of where the end in mind is. I think it goes back to what I said earlier is how are you solving a problem for a payer? How are you leaning in to say, look, I know you have this problem. I'm going to go do these things, and this is why I'm different. This is why I'm able to do this something at scale for this population that nobody else in your network can do, and really make yourself sort of invaluable to that plan. And then I think the last piece is creativity, which is a word we don't often use in sort of the healthcare space, but because we don't have the same ACO REACH constructs or other things that we can point to that the government said, let's go do this and everybody will follow it, it's going to look different. And that sort of sucks for now, right? Is all of us probably craft different programs that look different. So providers right now have to do 17 different things to satiate 9 different payers that they have. And I think part of it is really how do we come together as an industry, right? Not payer versus provider, but holistically to say, hey, this is how we think this care should be delivered. These are the things that we believe make people better. And then really figure out how do we sort of standardize those so that we can all do the same things. I think we all spend oodles and oodles of money, as all of you do, trying to do these things individually and uniquely, when if we said this is the right way to do it, let's all get behind it, it would make a whole lot of things a lot easier.
Got it. Makes a lot of sense. Anyone else, feel free to answer, or we can move to Q&A, but go ahead.
No, just lastly, I actually really hate talking about money, which is really, it's not, I know, it's like, oh, you're on a panel about value-based care, but it's like, what is the general value of partnering with innovative solutions? And before you can even have a conversation about what does the ROI look like many years down the road, like, are your members happier? Are your providers happier? Are they engaged? There's so much more to look at that then eventually translates potentially into money.
Yeah, I mean, I agree. When Talkiatry, talks to payers, new payers, even existing payers, it starts with saying, and sometimes they come with their own views of, hey, this is what we want to do and what we get to. And honestly, sometimes we dial it back and we say, we would love to get there in a couple years. But honestly, we don't want to start with that at all, actually. We want to build a relationship. What are the issues that you're looking for? Let us demonstrate that we can hit those things, and then we can have a conversation about where we can go once we all understand the capabilities here, right? We don't want to overpromise. We don't want to underdeliver, but I think we want to build the relationship and say, how many members are we treating? Do they like their care? Are we providing these things? Great. Now let's talk about what issues you're trying to solve and how we can enter into performance-based things to kind of hit those, right? So I totally agree with that, and I think that's great color for people in the room who are trying to establish these types of partnerships and relationships. We have some time for Q&A. If I think we have a couple minutes, so we have time. If people, okay, we have one over there. I think there's some microphones here. The Slido question didn't work, but if there's any mic to hand around, that'd be great. Otherwise, feel free to talk very loudly.
Is this working? Oh, it is working. Hi, everyone. Andrew. I don't want to name everybody. I like Andrew. My question here is, what steps are you all concretely taking to engage your provider network to actually have these conversations outside of rooms like this? Practical, actionable items that the provider can actually get meaningful engagement from the payers. And of course, we all know payers depend on providers for network availability, stability, and quality. Providers might feel like they're delivering, but they're not getting much from the payer. So I'm just curious if any, tips and tricks we can hear from you, Andrew.
Yeah, I think so. What we've been doing over the past 2 years I've been at Evernorth is we're growing our provider experience approach to give those providers that one-to-one person that they can go through on the provider experience team so they get heard. Along with our contractors, right? I think in the past, it was very much what we call like hard contracting, right? You only reached out to your contractor, you threw out a number, and that was it. That's not partnership, right? Partnership is, let's really talk about not only your contract, but where are you going? What's your strategy? How can we be helpful? And it not only benefits our providers, but it does benefit us as payers too, to know a little bit more of where you want to go so that we can prepare for those things. And as our provider experience team continues to grow, we hear more and more that if they're given that liaison within our company, someone they really know who to go to, it just improves on that experience. And that's our hope, is we continue to grow that, we can find more and more ways to see what you're doing creatively.
Yeah, I mean, I would say that they come to things like this, right? And I think that we've had some pretty meaningful relationships with everybody on this stage prior to doing something like this, and so I think it's just a relationship, just like it would be with anyone else that you build over a period of time. But what I would say, just as a provider, which is don't be scared to reach out. Send them an email, honestly, sometimes, and just say, hey, I'm interested in having a conversation about this. Is this the right person to speak to, or how do I get to that right person? And I would say that I haven't really ever, obviously they're incredibly busy people, but generally speaking, I mean, they want to hear these sorts of things. They want to have this engagement. That's why they come to things like this. And so, sometimes I would just say pick up the phone or shoot an email and try to get in contact with the right person, and they're here to help to the extent that they can. So honestly, sometimes I'd say just do that, right? It works.
Yeah, I will say that, obviously we have a network that has probably over 300,000 providers in it. So, the experience of, a single shingle provider, who's operating one office in, some region, probably will not have the same experience that a Talkiatry will have, or that an Alma or Headway will have. Resources limited, and so like that people resource to work with folks is a little bit limited. And so in the effort to make progress but not boil the ocean, we've started, to really kind of intentionally work with the folks that are big first. A large portion of our membership that gets behavioral health care goes to a handful of very large providers at this point.
Yep.
And so that's where you do see those very deep relationships, these very kind of, deep conversations about value-based contracts, ongoing, quarterly meetings, things like that. Also, when we get to people that kind of fill a specific niche, those subspecialty providers that do something really unique, we look for those solutions. I got people here in the front row who are like furiously taking notes right now, but I work with them all the time. Like, we set up forums where we have a couple of days where we're having providers just come in and kind of present the thing that they do to us, so that we can make a decision on whether or not there's a use case. We have folks that are coming up with different products that our plan sponsors may be interested in. We have the regular network operational aspects of, like, making sure that we contract with the folks that our members want to go to, and our plan sponsors expect to have them in network. So there are multiple different ways in which we interact with the provider side of behavioral health care. But there are specific things that we're doing with some of the bigger ones that I think fill a need for us, and we have enough bandwidth to actually do something effective and creative with.
Awesome. Definitely go for it.
So the one thing I want to also hit on, as everyone's been talking and thinking about relationships with payers, and some people who have negotiated with me are going to see a soft side of me that maybe you've never seen.
We would love to see that side, right?
But I just want to remind everyone that when you're working with the payers, I've been with Beacon, now I'm with Evernorth. I have never had a single person in our customer service side, in our provider relations side, that isn't working their tail off every single day to solve your problems. It may seem sometimes like they're not trying to do that, but also remember how complicated healthcare is. We all know this in this room. So just remember, every single person, especially in those provider relations teams and things like that, are there to help you. And we are going to continue to push for those partnerships. But I just want to stump for those people, because they work their tails off every day and they want to make things better for all of you.
Yeah, I think that goes for everyone's organization on this stage by far. I think we're over on time here, but quickly, how has it been working with Talkiatry after all the things we're talking about on this stage? I'm curious. It's a shameless kind of question here.
Yeah, I would say excellent. We're so.
Oh, that's good. Okay,
Right.
I forgot.
Well,
Some of my teammates are in the crowd here.
I'm sitting next to a psychiatrist, but we cannot birth more psychiatrists, right? There just will never be enough. So it's really important to have an organization like Talkiatry who helps to bring psychiatry in as an accessible point within a network is important.
Yeah, I mean, I'm a little partial to psychiatrists and psychiatry first,
Sure.
as a psychiatrist. But I think the other point is, like, I asked our network folks, like, what's it like working with Talkiatry, and they had good things to say.
Good, that's good.
So we have general contract, we have 1 or 2 specialty contracts.
Yeah.
And you guys have been very good partners, and so I think you guys fill a need that we have for our membership to get that psychiatry first care that I think is fairly unique in the space.
Awesome.
Yeah, I think lastly, it's been a first of its kind experience in terms of what you've been asking, the questions you've been asking them, how you've been asking them. And so I think there's nothing but continued advancement around what that might look like.
Awesome. Cool. Well, listen, I appreciate you all for staying a little bit over, but I hope the panel was interesting. and feel free to come up and ask us some questions afterwards. Thank you.